Okay. So, dear colleagues, ladies and gentlemen, thank you very much for joining us today. It's always a pleasure. Today is our second meeting. If you want to call it webinar, you can. And it is the second in the EndoEngage project that we started in 2025 with our society, with which I am really proud to be part of, which is the European Endometriosis League. This is just a part of a lot of activities that we have launched this year. Hands-on training on cadavers, a lot of awareness issues, and expect a very nice awareness program in March, because March is the Endometriosis Awareness Month, but also in all the months we have some activities and awareness projects. And today we are honored, really privileged to have with us Dr. Sue Freeman. Dr. Sue Freeman is a consultant radiologist in Cambridge University Hospital, and she's one of the most experienced radiologists in female reproductive organs and reproductive health I've ever met in my life. I personally learned a lot from Sue, and we invited her, and she kindly accepted the invitation to explain to us the role of magnetic resonance imaging in diagnosing deep endometriosis. This is a question that has been raised, and again, we are just trying to reply, because for a long time, laparoscopy has been considered a gold standard for diagnosing endometriosis. However, deep endometriosis, the more we learn about it and the deeper we go, we learn that deep endometriosis is totally in another room. It's present in the retroperitoneum. And I won't take much of your time. I would pass the word to Aline, who will explain a little bit of how the program will be run and the questions and answers, and then directly to Sue Freeman. Thank you very much.
Thank you, Mohammed. Thank you, Stu, for having you with us this evening. So the program is going to be exactly like last time in January. So we'll be having a short presentation, and there are still people coming in, so I'm busy clicking admitting. So we've reached 180 now. Dr. Sue Freeman will have her presentation about MRI and the diagnosis of endometriosis. In the meantime, we are happy to receive your questions in the chat box, and at the end, we are very happy to discuss them. Before starting, I'd like to thank our sponsor, Gedeon Richter, for supporting this project. And for that, please allow me to share with you a short video.
What does it take to make a medicine? You need to shift your perspective to see success comes from a series of innovations. Without the dedicated work of our highly trained researchers, no such progress would be possible. It is today that experts need to think about the disease of tomorrow, and premium quality requires the latest. All these aspects come together to create new treatments that will improve the health of millions. This is what we work for every day. Gideon Richter, health is our mission.
Thank you. So, Mohammed, Sue, I guess we can proceed.
Please.
And we're happy to.
The floor is yours.
Your presentation.
Okay, right. Well, thank you very much, Mohammed and Aline. Thank you for inviting me to be here today. And hopefully, does that look okay?
Yeah, amazing.
Okay. To be honest, that's probably the most challenging one of the whole meeting. Okay, the very first click to get that ready. Well, thank you everybody for joining. You know, what a privilege, what an honor. And I am going to do my best to talk about MRI in endometriosis. What can we what can we learn? And we're just going to explore all the different facets that that MR can bring to endometriosis care. No conflicts of interest, and off we go. I think the first thing I need to say that ultrasound is absolutely the starting place for all patients on their journey with suspected endometriosis. And when I say ultrasound, I mean ultrasound that is done properly by somebody who is experienced and trained in endometriosis scanning. Okay. And we know that in the right hands, ultrasound is excellent in the identification of deep endometriosis. So I just want to lay that down as the absolute ground truth. Okay. Ultrasound. But MRI absolutely has its role where we can look at areas of the body that are slightly harder to get to with ultrasound. Sometimes bowel just won't behave. We can't get to all the areas that we want to. Or perhaps it's beyond the pelvis. Perhaps it's a really complicated situation where the uterus, the bowel, the bladder, the ureters, everything is involved. And in which case we're then on to thinking about surgical planning. And in that context, having the MRI images in a multidisciplinary team meeting where we can have all the surgeons, the gynecologists, the bowel surgeons, the urologists, all looking at the images together, where we can plan and make some really preemptive decisions about who needs to be in the room at the time of surgery. Okay, so I'm going to be looking at the protocol. How do we do the images? And I will be explaining a little bit about what the different MRI sequences are, not too much. I don't really understand all the physics myself, so there we go. Then really detailed, typical MRI findings in each of the locations. And as we go, looking at these kind of illustrations and cases as we go. So MRI, highly sensitive and specific in identifying deep endometriosis. And for those patients, as Mohammed's already said, those ones with dense adhesions, the pouch of Douglas where the uterus and the bowel are stuck together, it limits assessment by laparoscopy. For those lesions that are behind the peritoneum, then of course laparoscopy will never see them unless incisions are made and then we go deep inside. So MRI is excellent in those cases so that we can decide what the surgery is going to be even before the laparoscopy happens, and trying to move away from this idea that we could do a laparoscopy just to look and see about endometriosis. It should be that laparoscopy is done with the intent of treatment, knowing exactly what's there already mapped out. Okay. Problem solving, yes, those patients who have a normal ultrasound but classical symptoms that sound like endometriosis. Endometriosis and adenomyosis can cause the CA125 to be raised, and also an endometrioma will not always follow the textbook. So we talk about how an endometrioma should look on ultrasound, but sometimes it's not. Sometimes it's septated, sometimes there are little nodules, but MRI is excellent in the characterization of these lesions. And we've already talked about this surgical planning, wide field of view, okay? So there's the protocol, looks a bit scary, but if I break it down into 3 plain T2 weighted imaging, and when I mean T2 weighted imaging, we're thinking anatomy. And so we're going to be cutting the patient, not literally, but just with the images, in 3 different planes: sagittal, coronal, and axial. Then the T1 weighted imaging, which helps us to identify blood and fat. And then by applying fat suppression or fat saturation, we can then suppress the fat and blood products will actually become even brighter. And I'm going to show you examples of all of this. Then when lesions are quite complex, we may want to give intravenous gadolinium, or we might do diffusion weighted imaging, just to make sure that we're not missing any malignancy. And at the bottom, I've said intramuscular or intravenous buscopan is essential. And what do I mean by that? This is a drug which stops the bowel from peristalsing. And so you know that your bowel is moving constantly. Well, there's a lot of bowel in the pelvis. And if I show you this sagittal image, this is without buscopan. Okay, and all of these blurry blob shapes are actually bowel, small bowel. If we give buscopan, look at the difference. And so you can see that by giving this drug, it's in the system for about half an hour, 45 minutes, it's gone completely, but we can see the contour of all of these bowel loops. And this is absolutely essential if we're going to pick up small deposits of endometriosis. This, useless. This one, then we can start doing the mapping. Okay. So when we talk about T2 weighted imaging, this is the anatomy, this is the sagittal plane, where you can see the patient is being cut right down the middle. And if I just play through this, we're just going from one side of the pelvis all the way to the other side. It's an anteverted uterus. We can see the bladder at the front here, the rectum and the sacrum at the back. And here's the high signal intensity endometrium, low signal intensity junctional zone, and the outer myometrium, intermediate signal intensity. So bright, dark, and then grey. The same sort of picture is then seen in the cervix, where we see the bright endocervical glands, then the stroma, and then the muscle around it. We can see beautifully vaginal wall, posterior vaginal fornix. Again, with the coronal plane, we're going right to the back of the pelvis, where we can see the sacrum, the muscles, through the rectum, back through the cervix here, coming further forward, we can see the uterine body. And look at the nice gap between the uterus and the bladder that we can see just squashed there. And of course, we can see beyond, can't we? We can see the fat beyond the peritoneum, and we can see bones, hip joints, etc. And then finally, we're looking at the axial plane. And on this, we can see the uterus, cervix coming right down towards the perineum, vagina, urethra, pelvic floor muscles coming back up through the vagina, cervix, the uterine body is coming into play. We've got an ovary here, another one here. So you can see, and we could spend half an hour just going backwards and forward on this, looking at all the blood vessels. We could look at all the neural foramina, the course of the nerves coming through the pelvis, but that's probably another lecture altogether. And so if we say, well, you're obsessed about anatomy, well, yes, we are obsessed about anatomy, because pathology is present when the normal anatomy is absent. Okay, so if we say on the left that this is just a normal sagittal view of the uterus, you can instantly see that the patient on the right hand side of the screen is just completely different. This is a very bulky uterus. We can see the uterine fundus is at the level of L5, so very bulky. The junctional zone here, thickened. Instead of a normal fat plane along the back of the uterus, we can see that there's a low signal intensity nodule, which is then attached to the rectum, where there is a muscle invasive deposit. We can see underneath that, actually, several loops of rectum are then being pulled up and have this very odd triangular shape. One image. That's all it took, one image, and we can already say this patient has diffuse adenomyosis, deep pelvic endometriosis with a bowel muscle invasive deposit. That's what it takes. Then we move on to the other sequences, and this is just one slide to illustrate what we're looking at. So the T2 you are now familiar with, and so this shows us our anatomy, and we can see that there are 2 ovarian lesions. This is the patient's right hand side, and we can see there's a mottled bright lesion. On the patient's left hand side, pointing with the red arrow, it's a grey lesion going from light grey down to dark grey. We call that shading. And if we follow that lesion over onto the T1 weighted imaging, we can say that it's high signal intensity. Then that high signal intensity or bright lesion becomes even brighter with the fat saturation. What do we mean by that? Well, if you look at the subcutaneous fat, it's bright on T1, but if we add fat suppression or fat saturation, it becomes black. The same here. We can see on this lesion, it's bright on T1, but when we come over here, it becomes black. So this has got macroscopic fat in it that suppresses with the T1 fat saturation image. So we can say this one's got fat in it, it's a dermoid. This one goes from bright to even brighter, and that is characteristic of an endometrioma. We don't mind that it has little septations in it. There's nothing abnormal about that. It's an endometrioma. And that's how we use the different sequences. Then that leads us on to different specific MRI findings in endometriosis. And we can use lots of different classifications. This one is the hashtag Enzian, which is quite nice because it's colourful. It is a classification that suits itself to surgery and possibly ultrasound, not maybe so much for MRI, but we can adapt it. None of them are completely perfect, but it's a nice way to go through the different elements of endometriosis and what we might be looking for. So if we start off with the first one, peritoneal or superficial endometriosis, can we see it on MRI? Well, only if it has blood products in it. So we can say that on the T1 fat saturated images, if we can find some tiny little dots of high signal intensity, then, and this is along bowel loop, this is along the back of the uterus, we can say this is probably superficial endometriosis. You can see a little endometrioma tucked away there. So not perfect, we can't see powder burns, we can't see little cystic blobs, but we can if it has some blood products in it. Endometrioma, ovary, yes, MRI is fantastic at that. We've already covered it. We're looking at the shading, bright on T1, even brighter T1 fat sat. There we go. A lot of people come back to me and say, so how can you be sure it's an endometrioma and not a hemorrhagic cyst? Well, this is a hemorrhagic cyst, okay? A hemorrhagic cyst is a completely physiological entity. This is one bleed after one ovulation. So very minimal amounts of blood. We can see that there is a cyst in the left ovary, almost a reticular pattern to it. On ultrasound, you'd be quite familiar with how that would look. On the T1, well, if you use imagination, perhaps it's a little bit bright dependently here. T1 fat sat maybe a little bit, but it is nothing like what we've been looking at. It's not bright like a light bulb, even brighter. So we can say that the bleed from a hemorrhagic cyst, it doesn't contain lots of chronic blood products, and therefore we will not be confused. Moving on to tube. So for the hashtag Enzian, they are looking at adhesions, motility, even patency. Now, of course, we can't really do patency on MR, but we can imply, we can look at the fallopian tube, and if it is dilated, fluid filled, then we can probably infer that it is blocked. So, and going back to adhesions, sometimes you can see the adhesion, or sometimes you can see the effect of the adhesion. An adhesion is typically a very fine black band on MRI. But what we tend to see is the adhesions holding the organs into an unusual position. Now, there's no such thing as an absolutely typical pelvis, but the uterus is usually about in the middle, and the ovaries are usually along the pelvic side wall. But when they are drawn downwards and back and tucked behind the uterus and next to the rectum, it just looks like an unusual place, and that makes us think that there are adhesions. So this is the commonest one that we can see, or that where this is a coronal T2 weighted image. So the patient's cut this way. You can see the hips here. So, and in the middle is the uterus. At the back is the rectum, and these two structures are the ovaries, and they are touching in the midline in the pouch of Douglas, and these are called kissing ovaries. If we were to look on T1, we would see that there are lots of little endometriomas in there as well. But the reason they are held there is because of adhesions. This different patient, this is an axial T2 weighted image, and we can see the uterus and then the rectum, which is pulled up here, and then next to it are two ovaries. Again, they're not where they normally sit over here. They're pulled down and back, held by adhesions. Some more examples that we can see of adhesions where there's a little bit of thickening along the back of the uterus, and then these fine bands moving from the back of the uterus to the bowel. We can see a few of them. On ultrasound, of course, we would see them. We would see that there was probably a negative sliding sign on ultrasound. The uterus and the bowel wouldn't move separately. And we would look in the pouch, in the posterior vaginal fornix, and we would see this tethering between the bowel and the uterus. On MRI, we may see these adhesions, or we might see the effect of the adhesions. So bowel loops should be round or oval, but we can see here that all of these bowel loops are pointy or triangular. And that means that there is something pulling on them. And by that, we know there's going to be adhesions. We talked about adhesions might wrap themselves around the end of the fallopian tube, causing a blockage. And here we can see this fallopian tube is fluid filled, dilated. Okay, we can see that lovely tubular shape quite clearly filled with fluid, bright on T2. And then finally, where the money's all at, the deep endometriosis, this comes into its own with MRI, where we can do some really good detailed surgical planning, mapping of the disease, so that we can at least inform what may be found at surgery, and just make sure the right people are in the room. The length of surgery could be estimated, etc., etc. So deep endometriosis, and what do we mean by that? Well, recurrent episodes of bleeding within the ectopic endometrium, so endometrium outside of the uterus, causes inflammation and then fibrosis. And that's seen as thickened, low signal intensity bands, often spiculated. And then when those deposits infiltrate into the bladder or the bowel, then those ectopic endometrial glands induce fibromuscular hyperplasia, big word. But what that is are these low signal intensity nodules that thicken the bladder or the bowel. It makes the bladder or bowel wall really nodular, bulky looking, and they are going to be low signal intensity on T2 and T1 weighted imaging, because they're muscle and they're fibrosis, and both of those things are low signal intensity. It's not often that we see blood products in those infiltrating lesions, but if we're going to see them, then it's best to look with the T1 weighted imaging with fat saturation. And then we move on to a methodical approach so that we can read the image to make sure that we don't miss anything. And I always think you should start where you're going to see most of the disease, and we see most of the disease in the posterior compartment, and we're going to go through this bit by bit. But the uterosacral ligaments, the torus uterinus, posterior vaginal fornix, rectovaginal space, bowel, they've got lots of names, and I think the most important thing as radiologists is that we speak the same language as the gynecologists and the colorectal surgeons in this case, just to make sure that we're all talking about the same anatomy. Then we move into the anterior compartment with the bladder and the fold between the uterus and the bladder. And then middle compartment, where we think about the parametria, the ureters, the nerves, etc. Okay, so here we have a patient with thickened uterosacral ligaments. Now, what are the uterosacral ligaments? Well, that's the condensation of the mesorectal fascia It courses from the back of the cervix, the junction between the uterine body and cervix, the torus uterinus, courses backwards and round to the sacrum. And it can be smoothly thickened, or it can be have a nodule on it. Of course, if it's got a nodule, we know absolutely that it's involved. And here we can see a large spiculated nodule coming all the way back towards the sacrum. Same patient on the axial view. This should be pencil thin, but it's like a marker pen, really thickened, low signal intensity, almost back to the sacrum. So not just proximal, but distal, which has its own implications with the hypogastric nerves, etc. Different patient again, we can see thickening along the torus uterinus, and then particularly again on the right, it's not always on the right side, it just happens to be these cases. On the right side, the uterosacral ligament is thickened, again coming right out towards the sacrum. Then we need to think about the posterior vaginal fornix. We saw really early on about that should be a nice thin line. Just here we can see the posterior vaginal wall, and we're following it up. It should be really nice, smooth, thin, but what happens? This nodular thickening. This is a deposit, deep endometriosis. And when we see that, we should look very, very hard, although it's not difficult in this case, to see its paired lesion within the rectum. And we call this a butterfly lesion or hourglass, lots of different names, where those two lesions are sitting, touching each other. Posterior vaginal fornix and rectal. This is bowel muscle invasive. But look, this is fluid in the pouch of Douglas. Okay, this is the peritoneal reflection. And this large lesion is absolutely behind the peritoneum. So this would not be visible on laparoscopy. Another case here, we can see there is a large lesion. It should be thin like this, coming round posterior vagina wall, and then a large lesion posterior vaginal fornix. And again, next to it, a huge lesion within the bowel wall. You can see that several centimeters, maybe 5 centimeters. A challenge for laparoscopy? Absolutely. Even though it's so long, this is an endometrioma that is just obliterating the whole of the pouch of Douglas, the whole of the pelvis pretty much. It wouldn't be able to access it without draining, etc. This is the axial view, just to show you again that the bowel muscle invasive deposit is here, abutting and infiltrating into, actually in this case, not just the posterior vaginal fornix, but infiltrating into the uterine muscle itself. And then bowel. So bowel endometriosis affects, it's difficult to know the percentage, but maybe up to 40% of women with deep endometriosis. And obviously most commonly in the rectum, but on MRI, we have quite a lot of bowel to look at. So it's really important that we look in all 3 planes on T2. We need to look sagittal, coronal and axial, because it may be that you only see it in one of those planes because of the way the bowel loops and curves. And particularly endometriosis is so sneaky in it can sit in amongst a little loop of bowel and holding it into a curve with it just in the center that you might only see from one plane. So here we can see again next to each other, 1 and then 2. Why is MRI helpful? Well, ultrasound, of course, it's going to see the rectal lesions, but as soon as they start to come out, they're along the pelvic side wall, sigmoid, it can be much more challenging with ultrasound. And to know exactly the length of the disease and the distance that is from the anal verge helps with surgical planning. Is it a shave? Is it a disc excision? Is it going to be a segmental resection? How far from the anus is it going to be? Is there going to be ileostomy, etc., etc.? So really important. And what we've learned is when we find one bowel muscle invasive lesion, don't have satisfaction of search, look again, because there may well be another lesion. Here we can see a patient with the axial view, this muscle invasive deposit, and actually the mucosa of the bowel sometimes is unhappy with the lesion invading, and the mucosa can be quite bright, slightly inflamed looking. That's why you can see that white line over the top. So this is a good example where I made a mistake. So I did the ultrasound, and the ultrasound probe was hardly inserted, and I could see the large bowel muscle invasive deposit. Yes. But what I hadn't appreciated was that it involved not just the rectum, but also this loop. And if we go to the axial view, this is the rectum at the back, but this loop swooping down into the pelvis is the sigmoid, and this lesion is in the mid-sigmoid colon. So two lesions stuck together, which of course has a completely different surgical approach. And for this patient, yes, large rectal nodule, which we can see there with the arrow, but if we look again, there's a lesion in the small bowel and wrapped around the appendix. Cecal deposits can be really difficult on ultrasound unless the patient specifically points and says the pain is here, and you look, you may well see the deposit if it's large like this, but otherwise it's very, very challenging, and not just a cecal deposit, but also within the terminal ileum for this case. This is a lady that we remember very well because she had had several ultrasounds, had like at least one laparoscopy, all clear, no endometriosis. But the MRI was requested because she had symptoms that sounded like she had endometriosis. So here is her MRI, and this is a sagittal T2 weighted image, and it's right out at the pelvic sidewall. And what can we see? Well, yes, we can see an ovary, but next to it, this large bowel muscle invasive deposit. Okay, and if I show you in the axial plane, there it is, right out at the pelvic sidewall. So it's not in a typical place that we would be able to see on ultrasound. The bowel lumen is on this side, so if there was gas in the way, we wouldn't be able to see it. Challenge. And because it's stuck to the pelvic sidewall, then it wouldn't be seen at laparoscopy. So on every level, it was very challenging, but MRI was able to show this lesion. Another case, not to labor it, but lesion within the bowel, 3 centimeter gap, and another one, just to help with surgical planning. Okay, so anterior compartment, urinary tract endometriosis is quite rare, but when we do have it, it's usually affecting the bladder. What we see more commonly is endometriosis along the anterior serosa of the uterus, and then infiltrating into the UV folds, so that bit of fat that's between the uterus and the bladder. Okay. So in this case, we can see the arrows pointing to a low signal intensity nodule. It's probably just about going into the bladder serosa there. If it goes even further, then muscle invasive disease within the bladder can be quite florid. And here we've got disease along the front of the uterus, disease filling the UV fold, and disease infiltrating through the muscle of the bladder. So the bladder muscle is this black line, and the black line should be thin and smooth all the way around, but suddenly absolutely thickened. You can see all sorts of little cysticky bits in it. Actually, the bladder lesions sometimes do have blood products in, so well worth a look on T1 FATSAT. We need to look in all the planes because we need to tell the surgeons how close that lesion is to the ureters. Is it going to affect them? Are we going to need to plan surgery differently? And here we're just pointing at the urothelium heaped up over the top of that bladder muscle invasive. lesion. But look, we can see that the endometriosis is also escaping out to the side, and it's wrapped around probably about half of this distal ureter, and it's causing the ureter to be dilated and, yes, hydronephrosis. And unfortunately, as is the case with endometriosis, this is often very silent, and you can see here that the meat, the thickness, the parenchyma of this kidney is much thicker than on the left side, and so this kidney has been obliterated for a little while now. So that kidney is probably not working. Ureteric endometriosis. Most commonly, the ureters get involved because of fibrosis, the extrinsic fibrosis within the parametrium or the uterosacral ligaments that pulls and occludes the ureters. And again, we shouldn't see ureters as standing columns of fluid, which we can see here and here, and a really abrupt cutoff where we can see this spiculated fibrosis around. This is an intrinsic ureteric nodule where we can see just in here that ureter has got thickening of the wall around maybe 3/4, and this is an endometriotic deposit actually on the ureter itself, but that's much less common than the extrinsic form. Parametrial endometriosis, we need to look at that in every scan. Again, whilst the ureters might not be involved now, we need to judge whether they are at risk. So here we can see that there is a band of fibrosis within the left parametrium. That's the axial. And then this is the coronal view, where we can see again this fibrosis in the left parametrium. And this, you'll have to take my word for it, is the ureter. It is very close. And when we are scrolling through the images, instead of the ureter taking its normal course out of the bladder, sweeping up along the pelvic sidewall up towards the kidney, that fibrosis tends to pull it in a zigzag in. Okay, and when we see that, we know that we need to monitor those ureters to make sure that they're not at risk. And finally, we've got time, just to think about some other areas. We say that MRI has got this wide field of view. That's why reporting endometriosis takes time, because there is a lot to look at and we don't want to miss anything. So here we can see a lesion in the anterior abdominal wall, commonly associated with cesarean sections or previous surgery. Another patient here with cyclical pain in the groin. This is an inguinal canal deposit. This patient had pain after episiotomy, and this is endometriosis that's found its way down into that surgical scar. And then diaphragmatic, we don't always image the diaphragm, but if there are clinical symptoms that are suggestive of diaphragmatic endometriosis, then we will perform a specific sequence that helps us to look. And here we can see just little nodules under the right hemidiaphragm, between the diaphragm and the liver. This is the liver here. So another one quite unusual within Morrison's pouch. Again, cyclical right upper quadrant pain. And then finally, not to forget about the pelvic sidewall and pelvic nerves. And this is just a coronal T2 weighted image, nothing fancy, just a standard image. And it's just to show you these are the nerves and how beautiful the sciatic nerve is demonstrated on MRI. We can see all of those tracts beautifully. So if we can see the nerve, then we need to make sure that the nerves are unaffected. And I think my plea to any gynecologists who are on the webinar is, if the patient has symptoms suggestive of nerves, please tell us so that we can be quite specific when we look. Here, you've seen this bowel lesion before, but what you weren't looking at was this fibrosis that's sweeping out from the parametrium out to the pelvic side wall. And look, we're in the retroperitoneum, and this bunch of fibers here is the right sciatic nerve. So it is right up against the sciatic nerve. Again, patient we've seen before where our lady had the lesion up against the pelvic sidewall. It was adherent, but look at the endometriosis. It's travelled through the retroperitoneum, through the fat. It's wrapped around a ureter. It's kept going. It's all the way along to the obturator internus muscle, one of the pelvic muscles. And here is the sciatic nerve. Okay. So, I mean, this is just to show when we are discussing patients in the MDT, we have the ability to scroll through images. We can go over them again and again. We can discuss how far something is away, likelihood of how we're likely to need stomas, etc., etc. It's just the utility of MRI. Ultrasound, I love, but obviously ultrasound is much better when you're holding the probe. That's all I'm going to say. Few messages. We've gone through the protocol. I've shown you why we do the different sequences. The most common findings of endometriosis on MRI, how we add some value, hopefully, and how we can use MRI usefully within the MDT. And any questions? That's King's College Chapel in Cambridge.
Thank you very much, Sue. This has been extremely comprehensive and didactic. So every time I hear your presentation, I see your videos and your images, I learn something more. Thank you very much. And obviously the role of the MRI in the multidisciplinary discussion before surgery, I cannot agree more. And I have to say that I don't know how many hundreds of cases I operated after your MRIs and after MDT discussions. And I have to say that I don't recall a surprise during surgery, because here we need to prepare ourselves. We need to agree with the patient. We need to agree to prepare the team that will be operating, the time of the surgery. And as Sue has just mentioned, also answer some questions that the patients usually ask about, for example, the likelihood of having a stoma, the nerves, the ureter, the reimplantation. Every word said in the report of the MRI is a step or a change in the plan or the strategy of the surgery. So thank you so much. We have some questions, Aline, is that correct? I can see here some questions. Okay. Guys, don't be shy. Please ask all the questions you have. We have time.
Right, should we start at the top? Let's see. Oh, hello. Yes. We're recording. Yes. Okay. What slice thickness do we use for the T2 and T1? So the answer is as thin as we're allowed to. Okay. So and as thin as is practical with your machine. It tends to be between 3 and 4 millimeters. I know that Isabel Thomas and Nagara likes to use some of the 3D sequences like Cube, where they're down at 1 millimeter, but I'm still not sold, because we lose some of the anatomical definition, which I think if I was allowed it as well, but I'm not. I get told what I'm allowed, to be honest. So my radiographers are in charge. Yes, Brill.
A quick question. If we're talking about technicalities, the performance of an MRI machine is measured in Teslas, right?
Yes, the strength of the magnet. Yes.
Is there any, I don't know, minimal requirements when we talk about endometriosis?
There are pros and cons to 1.5 Tesla and 3 Tesla. I would say the images that I look at are split 50-50 across the different sorts of scanners. We see a lot of images from all over the region, and actually a 1.5 Tesla that's driven well with good protocols is absolutely fine. sometimes the downside of a 3T, because we think 3 Tesla is the answer to everything, but unfortunately with a 3T, the gynae pelvis is moving more. It's not like a prostate that just sits there. And so we have to think about the movement artifacts that we would get, sometimes a bit more bowel gas artifacts, etc. So I'm happy with either, and you're really down to if you're radiographers, or we often have physicists in just to keep things moving along, because you suddenly see somebody show some nice images and you think, oh, I would like those images too. So get the physicist back, you get your application specialist back, and you say, what would you like? I want it to be better. I want to see endometriosis better. And the difference, I mean, Mohammed, we had one case where the young patient had decided she didn't want an injection of the Buscopan. Well, the images were very difficult and lots of movement. And, I was saying, I think there might be, I'm not sure, possibly a little. Anyway, Mohammed had a chat. She came back, she had an injection, and we saw all the disease. And it made all the difference. So yes, technical factors are really important.
So we have a lot of questions coming through, Sue. So I will select here and ask you a question from Marcus. Obviously, a lot of compliments and a lot of thanks for the excellent presentation, etc. But here, regarding the adenomyosis.
Yes.
Here, there are some questions about ultrasound and MRI. Is it the junctional zone thickness? Is it the Musa criteria? What do you think here?
Yes. Okay. So I think if you are confident that you are seeing adenomyosis on ultrasound, you are. And I think adenomyosis, if you make the diagnosis, what's the word, adequately, using are there myometrial cysts? Are there striations going from the endometrium into the myometrium? Are there hyperechoic foci in the inner myometrium? These are specific findings. Some of them are a little bit more difficult and perhaps not so specific. So if it's going to be the uterus is a bit globular or a bit vascular, I think we're looking for specifics. If you have a gut feeling but you haven't got the specifics, then go to MR and you can be specific, because the junctional zone on the MR is, I think, much easier than the junctional zone on ultrasound. I know with your 3D probes, I'm going to be shot with some of the people on the call, but I think MR is easier. Junctional zone should be 8 millimeters less. More than 12 millimeters, it's abnormal. Indeterminate between 8 and 12. But, and the but is the high single intensity foci within the junctional zone at whatever thickness. Okay, whatever thickness. So those are the myometrial cysts that we see on ultrasound. And if we see those, it is adenomyosis.
I'm glad that you mentioned ultrasound many times. I can see here very big names from Sweden, from Hungary, from Germany, all sonographers like
I know, I really I laid my ground truth. Ultrasound is still
and also here Taner Usta, who is also a brilliant surgeon from Turkey, he's asking you about the diaphragm and endometriosis. Do you need to, because I can see here that the diaphragmatic endometriosis, you mentioned the T1 and the blood, and so his question is, do you have to see her in a particular phase of the menstrual cycle?
So the answer
is
to
this
that
recommendable?
So if you can, then that's great. But life doesn't work like that, does it? And so I will scan patients whenever. Now, diaphragmatic endometriosis may contain blood products. It may be cystic lesions. It may be diaphragmatic herniation, where you can see actually liver is starting to come through the diaphragm, etc. But a lot of places run a standard T1 fat sat through the diaphragm in all endometriosis patients. I'm not keen on that because it would miss all of those ones that are just cystic lesions. And also, if you're going to do a diaphragmatic endometriosis protocol, it needs to be a proper one. So by that, I mean you're running sequences that are thin as if you're doing a liver protocol. It's time consuming, which is why, you know, I will only do it when the symptoms are suggestive of it, because it's a whole extra, you know, 20-30 minutes on the scanner on top of the 35 they've already been for the pelvis. So for some patients, that's actually pushing it. And for the diaphragm, of course, we're going to get them to be doing breathing regulation. So as they breathe, it triggers the scanner. So yes, it's so technical, thin slices. I tend to do it in 2 planes. I do axial and coronal, and it is T2, T1, T1 fat sat. So yes, did I say too much?
No, you explained it brilliantly. So thank you very much. Aline.
Yes, so the next question is about malignant changes in the ovaries and how can MRI detect that? And this was actually the topic we've had in January when we talk about malignant transformation of endometriosis, particularly Ovarian endometriosis. So yes, what do you think? How does MRI perform in terms of malignant ovarian lesions?
Yeah, it performs very well, but it performs in very much the same way as ultrasound. So instead of the endometrioma being bland chronic blood products, actually we're looking at a soft tissue nodule within the lesion, and soft tissue nodule on MRI is going to be intermediate signal intensity. It is going to be enhanced with intravenous gadolinium, and it will restrict on diffusion weighted imaging. So we've got all of those things. Is it common? No, we probably see it. How often do you think, Mohammed? Probably once every. Actually, the issue is we see it in the older age group, so they're not the ones coming with symptoms of endometriosis. In fact, the number of times that we have diagnosed these have been patients that haven't had the symptoms and have actually been undiagnosed until they arrive with imaging, and it's an endometrioma that has a lesion in it. That's certainly been my experience.
Can I just highlight one thing here? So 2 things actually that I learned from you today. I learned from you some years ago, but I would like to highlight them. Yeah, is that when we do an MRI for endometriosis, it's not that we send the patient and say, so look for endometriosis. We send the patients, and if we have clinical suspicion of nerve involvement, we refer them with a request to evaluate the pelvic nerves and the sacral nerve roots, etc. If we refer the patient with clinical suspicion of diaphragmatic involvement, we refer the patient. If we have any clinical doubt of ovarian malignancy or of malignant transformation, because we have looked with our ultrasound and we have seen atypical features, etc., maybe we need also to tell you this, because my understanding is that, for example, this would need also contrast, MRI with contrast if you want to be sure. Maybe, I'm not sure, you will tell us. And you don't usually do MRIs for endometriosis with a contrast. Am I correct in what I'm saying?
Yeah, correct. Exactly. We don't normally give contrast. Yeah.
Aline.
Yes. So the next one is a difficult one, even for people doing ultrasound diagnosis. So this is from Ioana, my colleague and my friend from Romania. So she's asking, how can MRI help us to distinguish between a residual lesion and the post-op recurrence, or just scar tissue?
Yeah, thank you.
Difficult one.
Well, the answer to that is hopefully what I've shown you is the MRI is largely showing us fibrosis, but it's fibrosis in the context of repeated bleeding and inflammation due to endometriosis. Now, of course, after surgery, even with the best surgeon, there is fibrosis. So trying to work out whether this is something that has been left behind, for example, that's often the question, isn't it? Is this recurrence? Is it something left behind? Is it fibrosis? Very, very challenging. If we have preoperative imaging, we can compare with postoperative imaging. But you know, this is a progressive disease, so we don't always talk about that. I've got plenty of MRIs where if patients decide no treatment, I'm just going to manage, I don't want surgery, I don't want any hormones, I'm just if we do an MR a few years later, we can see progression. So after surgery, I'm talking to such an esteemed group. I should shut up. Anyway, but we do we do see progressive endometriosis. So after surgery, of course, we could have recurrent disease. Is ultrasound better? Sometimes I think it might be, where we have had cases, and on the MRI, we've seen a lesion on the bowel, and I've said, well, I wonder if that's where you've done the disc excision, and that could just be some scar. And then we've gone to ultrasound, and actually the delineation on ultrasound for such a small lesion actually was better. So just throw that in the mix. We've got to use the modality that you're happiest using, the expertise that you have, but there's no magic. That's the short answer.
Perfect. We have also another question about the fat sat technique that you prefer.
Oh,
You find
we tend to
certain
use the
fat-
Dixon. Yeah, of course. Professor Dixon was in my department, so of course we use the Dixon.
Another question from Egypt. Do you routine from Tamer from Egypt? Do you routinely do abdomen and pelvis
So
when
we
you do?
routinely do kidneys and pelvis, and by kidneys we mean a very quick zoom through the kidneys to look for hydronephrosis, because we've had too many cases now. So we
Also in ultrasound?
exactly.
Okay, and here Ahmed, I think from Turkey, I know Ahmed. Thank you, very nice talk for evaluation of sacral and sciatic nerves. Which technique is better, 3 Tesla MR or MR neurography?
Yeah, I'm not really sure about the neurography. Hopefully I've convinced you with the standard techniques that we've got. As soon as you add neurography, you're just adding factors of complexity. Good T2 weighted images can show you the entire length of the nerve and whether or not it is near any disease, because as we've seen in the past, it doesn't have to actually be wrapped around the nerve, but if it's close, it can also cause some trouble. 3T, I don't think 1.5 or 3T. I think either would be fine. Thin slices.
Okay.
Fine. Yes, please go ahead, Aline.
The next question is coming from Sarah, and I suppose she's one of the patients joining our meeting this evening. So she's asking if there's any preparation necessary before going for MRI.
So this is when I say yes, but it's not difficult. So ideally bowels open, but if in the continent there's a lot of people who give an enema, but in the UK we don't, so I don't get a choice about that. And we usually say to empty your bladder about half an hour before the scan, because with ultrasound sometimes we get you to fill your bladder, but on MRI that's counterproductive because it makes you squirm and you move and it damages the images. So that is really it. So empty your bladder about half an hour. We don't want it completely empty because we want to see the bladder wall. So completely empty, not so good. So come hydrated empty bladder.
And here also a question, because I have recently seen a couple of MRI images so that they use gel in the vagina and the rectum. And actually here we have a question from one of
Yes.
our colleagues about this. If you see any help of using gel in the vagina and the rectum.
I don't. And the world is divided. So gel in the vagina to see vaginal lesions. Well, I think that's what a speculum's for. So, and a good gynecologist. So I think gynecologists can see the vagina. In the rectum, it can be useful. The issue with any installation of gel is that often it's not very acceptable to patients, because obviously we get them to squirt 5-10 mils of gel into vagina rectum beforehand. And also when they do that, they can introduce gas, and gas on MRI is the enemy because it distorts the images, it adds lots of artifact, and actually the gas can obliterate a small lesion in the rectovaginal space. So I'm not pro. I know maybe in France they do like it. There's lots of papers. Marc Bazot would say it's not a scan unless it has gel, but I don't think it has been detrimental to our diagnostic accuracy. So and maybe more patient friendly.
Great. We have, yes, we still have some questions, Sue. So please, after your permission, we can extend just 10-15 minutes if you don't mind. We ask you the permission before we start.
If people want to stay, but if people want to go also, we don't mind.
Your talk is very interesting, and here we are going in depth, and we have questions from very brilliant, eminent surgeons. So Mikkel from Denmark is asking you about the distribution of sacral nerve involvement because in their clinic in Denmark, which is a significant one, they have most of the lesions on the right side.
That's a I don't have any data, but I will now look. Thank you for asking that question. And you mean sacral nerve as in the sort of S2, S3, those ones?
Probably yes.
Yes, I mean sacral S2, S3. Hello, nice
Yes, hi, I can
presentation.
hear you,
Michael, we
Michael.
can
Yes,
hear you.
Hi, Mikkel.
brilliant.
Yeah.
Yes.
I talked with Horace about it. He has 50-50%, he says, but I talked to my very routine MRI doctor, and he has no doubt it's much more frequent on the right side. And if you look through the literature, it seems that other centers have the same.
That's so interesting, Mikkel. I have, other than I was showing you lots of distal uterosacral ligaments on the right. I will look at that. Yes, I don't know the answer. I'm not going to lie to you.
Great. And here we have a question from the first author of the hashtag Ancient, our friend and teacher, Jörg Eckstein, about what you miss in he's thanking you for the webinar and for the clear, comprehensive lecture. And he's asking you, what do you miss using the hashtag Ancient while describing the findings?
Yes, I think we don't have all of the things that you would have from laparoscopy, isn't it? This is the point. I think oh wow, we should have tea together. So we, as a group of radiologists in the UK and in the ESUR, we debate about whether can we use the hashtag Enzian? Should we be using the DPAI? How should we divide the pelvis up? Should we be doing it into 9 separate segments? Or we get ourselves into pickles with it. I think my main issue is obviously peritoneal, because we can only see the ones with the blood products in. We absolutely know that. Tubes, patency, well, we're only ever going to be able to call the ones that are blocked and filled with fluid. Mobility, with ultrasound, great, we can do the sliding signs, we can, you know, really move things around. MRI, not. It could just happen to be that that ovary is hanging out in that weird place today, and tomorrow it's not, because obviously I see a lot of patients that I've scanned on ultrasound and then we MR, or vice versa, and it's interesting how things yes, they really do move around. So MR, we do a lot of implication, this unusual position, possibly adherent, etc., etc. Whereas we know with ultrasound or your laparoscopy, you would see the difference. I think those are the main things. How you measure, I could keep going, couldn't I? Measure it, the way you measure uterosacral ligaments, I think maybe again a bit challenging on MR, but otherwise, yes, bowel, I think we can do bowel. I think that's good. But yes, we need tea.
Yeah, I think one of the main advantages of the hashtag NCN classification is that it's a code. And it's available for everybody on the planet, no matter what kind of language you speak. So if you're going to see a finding from, I don't know, let's say somebody from Philippines, and the report is not written in English, you can get a hashtag code and you will know what you're going to expect going into surgery. So having the common language, I think that's a huge benefit of the hashtag NCN classification. And in terms of the T compartment, when we talk about mobility of the ovaries, tubes, and so on, of course, that's a limitation of the technology we're using. So using the ultrasound, of course, being a dynamic examination, being able basically to palpate the pelvis of the patient, that offers extra information compared to the MRI, where we have, let's say, indirect signs of adhesions. We move on to the next question, and the next one is regarding the dose of Buscopan that you used before MRI, and maybe it would also be interesting to let people know that an alternative to the Buscopan would be the more expensive drug, glucagon.
Yes, absolutely. So anything that's an antiperistaltic, but I think it's 10 milligrams. I don't know, I want you to quote it to me. And I can see further down IV or IM. Pros and cons. IV hits the system really fast, but unfortunately leaves the system really fast. So you've got about half an hour on the scanner. Wouldn't give it until the patient's in the scanner. You've got half an hour, and then when it wears off, you get this sort of reflex hyperperistalsis that you can have. IM, longer to get going, but lasts longer. So you'd probably want to give it in a prep room before the patient hits the scanner, but it would last longer. Some people say it's not as good. So it depends on the way you're scanning.
Awesome.
We also have a question about the role of MRI in a strategy of surgery where you start in recurrent surgery for endometriosis. So yes.
I'm not quite sure where to take that. In strategy of surgery where we start in recurrent surgery, I guess you're starting from the baseline again. I guess it depends. We, as radiologists, we don't always know exactly what you've done. So please provide all the information. You know, was it a ureterolysis? Was it a segmental bowel resection? Which it sounds obvious, but actually some of those staple lines are really difficult to see on MR, a little bit easier on CT. So tell us what you've done, and then we can go from there. Often there is going to be fibrosis after a scan. So if you think there is residual disease, if you're worried about a patient, then of course baseline imaging is always good. We can always start with that, and then maybe in the future if there are symptoms, etc. But I don't know, there isn't a perfect world, there isn't a perfect solution. Yes, details of symptoms, always give us symptoms, then we know where to look. That's always helpful.
Perfect.
Yeah, I think that's a challenge not only for you as a radiologist, but also for us as surgeon when we have to go into the second, third, fourth, fifth laparoscopy, especially after open surgery. We're moving to the next question coming from Sharon. Is there any disturbances making MRI for endometriosis for lactating patients, and how much time after delivery is she correct time for doing the MRI?
Interesting. So I don't know if I'm allowed to give you Buscopan if you're lactating, I think is the answer. So if we could wait until you finish breastfeeding, so I don't think there's a time after delivery. I think obviously endometriosis tends to behave itself during pregnancy, more or less, doesn't it?
Should be.
Should be. We hope that's what's supposed to happen, but it's not the real world, is it? But yes, I don't think there's a set time. I think if you can wait until you're not breastfeeding, and then we can give you Buscopan, because we're going to get much better images. That's my only.
I've just checked regarding Buscopan. It seems to be acceptable to be administered when the patients are lactating.
Yes, you say that, but that's not necessarily what will happen in the
Absolutely.
hospital.
Absolutely.
Agreed. And here again, Sue, the question about Buscopan, because our colleagues apparently from the radiology, our radiology colleagues are asking again about Buscopan, and is it best to use orally or IV? We said that, yes, you
definitely not orally. I think orally just doesn't hit it. In fact, some patients come having already taken Buscopan in the morning, and we say, oh no, that, have more.
And what time you said? Probably half an hour before the exam, no?
Half an hour if it's going to be IM, if it's IV, on the table, because you only really have half an hour then.
Sure. And we have Erica Manzo, who is thanking you a lot. And we have
Thanks, Erica.
Gabor, who is asking, he is congratulating you.
2 questions.
Yes, you read the questions.
Okay. Firstly, you mentioned the hashtag endoEngage Session is adaptable for MRI. Yes, it is definitely. It's adaptable. It is. It is. Do I use it regularly? No, but I do use a template report which covers all of the details. So whilst it may not go into hashtag Enzian, each of those individual things are looked at with its own line and entry, if that works. Do you consider others? Yes. DPI, endostage, yes. If you use, how do you differentiate A, B, and C compartment severity according to size by these lesions? Whoa, what to affect more component? Yes. So it's really interesting, isn't it? So I know Isabel has done a really nice study looking at the DPI. It's slightly more complicated because it's into 9 different segments, but easier insofar as it's either a 1 or a 2, i.e. it's present or it's really bad. And really bad means it's going to be something like nerves and ureters. And the way she has classified it, because what's the gold standard? That's the problem with all of these studies, right? Is it MR? Is it surgeons? Is it histology? That's the problem. What is the gold standard? And so she was using the standard as length of surgical time and stay in hospital, which I thought was a nice surrogate marker of, how many points you score on the DPI, how long you're going to be in surgery, and how long your recovery is going to be. It's certainly one way of doing it. How do I differentiate A, B, and C according to size? I don't actually use the classification to that extent.
Tuesdays, may I ask
Yes,
one more
Gabor,
question?
Yes.
Yeah, because thank you for your honest answers. And it's really sometimes also for ultrasonography, really debate if it's A or B, or is it A2 or B1 or A1 or B2 the lesion. So for sometimes it's not a hard decision. It's not an easy decision to classify it. And you mentioned also that the uterosacral ligaments, you found during the if they are affected, they are ensickened. And do you have any cutoff in MRI for that?
So again, controversial, lots of papers. I think the sort of latest consensus that we've been trying to work on has tried to draw up what is definitely involved and what's we can say is not involved. So I think anything under 3 millimeters is definitely not involved.
Yes.
And the difficulty with that is the MRI is so good now that we can see the uterosacral ligaments in all of the patients, and I don't want to miss a single endometriosis, right? And so, you know, poor Mohammed has to cope with there's no endo. Well, you know, the uterosacral ligament is 2.5 millimeters. No, I try not to do that. But so if there's a nodule, yes, it's endo. If there's blood products, yes, it's endo. If we're in the context of hitting 4-5 millimeters, it might be endo. If it's asymmetrical, again, it may well be endo. But don't forget, endometriosis isn't the only thing that thickens the uterosacral ligaments. So, you know, it could be previous pelvic
inflammation,
and
operation,
yeah, exactly. So
fibrosis.
previous infection, we know that, but it continues to be a challenge. And I think, you know, for me, knowing that relationship with Mohammed, my surgeons, knowing there's nothing other than this.
I think that's a very important point to comparing ultrasonography and endometriosis, because we are tackling the same problem during the ultrasonography. If the uterosacral ligament a little unsickened, maybe a little inhomogeneous, but there is no clear nodule, then we have the advantage that we can ask the patient during the scan with the tenderness guided scan. But you have the other advantage that you can make again and again, scrolling through your images, so you're retrospectively too. So I think as I mentioned, we tackle the same problem, and thank you for your answers. Thank you.
You're welcome, Gabor. I mean, uterosacral ligaments on ultrasound are really challenging, aren't they? And I was talking to Katerina Exakustos last week, and I was saying, do you call asymmetry, or does it have to have a nodule? And she's nodule. She's very black and white.
That sounds like Katerina.
I don't know. I do sometimes when the uterosacral ligaments are asymmetrical on ultrasound, and as you say, we have the patient, so we can press on the ligament and say, and here, you know, is it all there? Yeah.
Perfect. Okay, so you have the questions. Give telegraphic answers.
Oh, okay. Yeah, not my strong point. Okay, we're running out of time. Okay, thank you for the interesting lecture.
No, it's for you.
Can a retroverted and retroflexed uterus hide lesions otherwise visible on MR? Can it be an yes? This is the question mark sign on ultrasound. Anteverted, retroflexed. Very challenging on MR. It could easily hide a plaque, but the very fact that the uterus is held in that position is highly suspicious, and that torus deposit often is associated with the uterosacral ligament thickening. Next. Was that good? Was that short enough?
That's amazing.
Once deep endometriosis is diagnosed, how often do you have to do checkups to see if it's progression or if malignancy has developed in the patient still has symptoms? What's the tracking protocol? There is not a particularly good tracking protocol. I could probably ask Mohammed to answer this one. Malignancy remains super, super rare. And so to do tracking on the basis of looking at that. The lecture from last month covered this beautifully. Mohammed, do you want to say something?
No, I agree with you, but the point here is obviously there is no consensus about which after which time should we do the follow-up imaging, ultrasound, MRI? And my opinion is we have to tailor it according to the patient. There is the patient that you feel she has some atypical features on ultrasound, but the rest is okay, then you can follow her up in short time. There is another patient, for example, that has some deep endometriosis, and she's young, and she might have some bowel involvement or parametrial involvement, and she decides for a reason or another not to be operated. So there is no one size fits all here. It's just that we have to tailor our follow-up to the patients. And I don't think we have to see our patients every month, as I also don't see that we have to scan our patients every 5 years, if that makes sense, patient by patient, and we tailor this to our patients.
Thank you, Mohammed. Perfect. Celine says she also adds a sagittal T2 fat sat. Oh, that would be nice, to little cystic lesions. Yes, super thin slices. Yes, if we were allowed, I would do every plane. But yes, thank you. And then turn up the stir. Many nerve symptoms related with nerve irritation, not nerve involvement. Correct. Can we easily discriminate nerve involvement or nerve? So what we can say is we can see the endometriosis. We can see it infiltrating through the peritoneum into the retroperitoneal fat. We can see I've got a beautiful case, not beautiful for the patient, totally understand, but the fibrosis has just crept out, and you can see the way it's hugging the obturator nerve as it courses down. So we can see touching, we can see surrounding, but we can see close. And I would also report close because we know that it doesn't have to touch. Anybody want to add to that? Can we, how often do you see endometriosis in postmenopausal women? Oh, good question. Well, the answer is yes, we do. And sometimes in postmenopausal women who have never been diagnosed, of course. In fact, you know, it may be a first episode of bleeding in the menopause, and they come for an ultrasound and we see endometriosis. Obviously, as estrogen levels drop, and then obviously the endometriosis will, I think, just regress a little bit, but we wouldn't see, yes, so we're seeing, I don't know if you'd use the phrase burnt out, kind of what was endometriosis. But yes, we can see that. We can see that. It makes for a very interesting conversation in ultrasound, usually, is the answer to that. Dear colleagues, can you share? Oh, colleagues. I think they might mean you colleagues.
Thank you very much, Dominica, but this is not a forum for discussing particular patients and giving opinions. Maybe this is a situation where you can, if you want an opinion, maybe you can send an email to one of us. But this is not a forum where we can discuss particular patients, if that makes sense. We agreed this at the beginning, and thank you very much for your question. If you send us your email, we'll be very glad to be in touch with you and to discuss the case with you. So let's move to Mariam.
Perfect. Mariam, thank you. Medical student, like to know online resources to study endometriosis images. Well, there are marvelous websites for ultrasound, aren't there? So obviously Suzanne Johnson's endometriosis ultrasound images, wonderful, lovely website, lots of really instructive videos. Oh, it's just left me. The Australian team have got a wonderful website with lots of, I want to say, I'm about to say something stupid. No.
No, but let's
101 ultrasound cases, something like that. 1001. I don't know. Fill in the blank if someone knows.
If you remember the name, Sue, what we will do is that we will upload the video on our EEL YouTube channel, And then we will put all the links that you will provide to us in the link. So can Mariam, thank you very much, Mariam, for attending. That's very rewarding, seeing also medical students attending with us in the in this web. This gives us a huge value. Thank you. And obviously, EndoEngage is working, and we are engaging as much as we actually aimed at. So thank you very much for being here. You will give us the links, Sue, and we will put them on the YouTube channel. Thank you very much.
No problem. No problem.
I think there is one last question from Jörg.
Okay.
Is there a role of dynamic MRI to understand the physiology and dysfunction?
Ooh, interesting. So you're meaning more along the line of sort of defecating proctograms, that sort of physiology. Well, I guess I guess when you're embarking on really very difficult surgery, knowing exactly what the pelvis, the bladder, bowel does before surgery, risks, knowing where the nerves are and what's after, it's not something I'm familiar with, but obviously within sort of female pelvic imaging, you know, another hat, pelvic floor imaging, postpartum imaging.
Jörg is asking maybe in adenomyosis. Jörg, why don't you
Yes,
please?
yes.
Oh, I'm sorry.
Yeah, use your microphone and ask the question.
Can you hear me?
Please, yes, we can hear you very well.
Yes, we
Please.
hear you.
A very, very great lecture and the discussion. And we're still struggling with the right diagnosis of adenomyosis because we have two different parties for describing by ultrasound or MRI. And this is not the similar, not the same description, not the same terms. So we are overlapping and we don't know if they are the same. So my question is to understand the dysfunction of the uterus, and there is a very nice videos from Ikuko Ota from Japan, and she makes a very, very beautiful dynamic MRIs how the uterus function. And I think like in ultrasound, we also look for the peristalsis of the uterus, and that would be very interesting for infertility and pain, understanding of pain. And that I'm sure that is a lot of work. It's more scientific, but to understand, we only make pictures, but we never measure the movement.
Absolutely. I couldn't agree more. And this is absolutely the downside of MR. We do see uterine contractions on MR, and often what that causes is a kind of bunching up of the junctional zone. The unwary will call that adenomyosis, but we know that bunched up junctional zone will move during the scan, which is why it's always nice to compare those areas later on. The patient's on the scanner for half an hour usually, and so that's when we can be confident to say, actually, that was a contraction. That's not focal adenomyosis, and it has flattened out. The uterus has changed shape, and this is exactly what we see with ultrasound as well. Often, when I start scanning a patient, the uterus just won't behave itself, will it? And so I will go away, scan the ovaries, and then we come back, and the uterus has relaxed. It's in a better shape. We can, you know, so that dynamic element is where ultrasound comes into its own, isn't it?
Why I'm asking this is because we did this more than 25 years ago. We did studies on the peristalsis with ultrasound and with the relation and influence on infertility. But now in the last, we do not read so much about this, and this is very interesting.
Yeah. It is. Research studies to be done.
Indeed, and there is also a lot now to say about dynamic imaging for the uterus, and especially in infertile patients with recurrent implantation failures, etc. And it is a topic that I think in the near future we'll have a lot in assessing patients with adenomyosis, also from the dysfunctional point of view of the uterus. So I think we concluded the questions. I can see here that Lorna wants to get in touch with you. Lorna, please email us at the EEL. Put your email address here, and we will forward it to Dr. Freeman. And we are very glad that we are also having some engagement and networking here. That's amazing. So last but not least, what I can do is, I think, Aline, we answered all the questions. Is that correct?
Yes,
You have taken the emails.
absolutely.
Super. Also for Lorna, she has just sent it. Okay, perfect. So, Sue Freeman, thank you so much. As usual, impressive and very engaging and very an interactive session. We are here for 1 hour and a half, and we still have people interacting, 250 people attending and asking questions, and very, very, very eminent names in ultrasound, in surgery, in pioneers in endometriosis, and also colleagues and students and radiologists and patients. So I'm so proud of what we are doing, and I'm really grateful for you, for your time and expertise, and for everyone who participated in the success of this. Thank you very much. Aline.
Yes, I would say stay tuned. We will soon announce the program for March, which is going to be a special EndoEngage session. So we'll be having a longer session in March, given the fact that March is the Endometriosis Awareness Month. So we'll be having open discussions, addressing as many questions as possible, trying to cover all the topics that concern endometriosis patients and healthcare practitioners. Mohammed, would you like to develop on that?
The 11th of March, and we will have, yes, we are arranging actually for very interesting expert panel where we will be not giving lectures, but exclusively discussing topics related to endometriosis management and diagnosis, and from different points of view, 360 degrees. This will be on the 11th of March. We will be very glad to have you all with us. Sue Freeman, please, if you want to say something to us.
No, it's just to say what an honor. Thank you for allowing me to join you, and hopefully we have all learnt something as we've joined together.
Thank you very much, Sue. Thank you for all of you who have honored us for being here, and we're looking forward to seeing you on the 11th of March for the endometriosis awareness meeting in the EndoEngage project. Thank you very much. All the best. Bye-bye.
Thank you.
Thank you. Thank you.